good afternoon, everybody, to the Quality and Safety Network. It's been a whole adventure already, so welcome to those who are new to the Quality and Safety Network, and I will just introduce how this network was created and what we've done already before handing it to Professor Michel. So the Quality and Safety Network exists now for almost 2 years, and the objective is just to share best practices and experiences about quality and patient safety within Europe. Because we find that just sharing best practices and experiences is one of the most effective ways just to learn about how our health system works and how we can improve quality of care and patient safety by inspiring each other. So as I said, it exists since 2019. You can see here the whole panel of webinars we already held the last 3 years. And they're all available on our YouTube channel, so don't hesitate to go and check a webinar out. If you have any questions, don't hesitate to come back to me. I will pleasantly make you in contact with the speakers. For this year in 2022, we already had a webinar about the quality indicators here in Belgium, how they're used in Flanders, the Flemish part of Belgium. In October, we'll have a presentation about how critical incident reporting is done in Germany. And then we'll have a focus on a Belgian breakthrough series collaborative with a Belgian hospital on how they improved quality and patient safety here within a 5-year program. And of course, today we'll speak about the French experience. You've been registered from all over Europe, as you can see, so it's always nice to have a lot of people connecting. And without further ado, I will leave the floor to Professor Dr. Philippe Michel, who was head of the scientific survey that was held in France about the adverse events in France. So, Professor, you have the floor.
Good. Thank you very much for the invitation. So I'm Philippe Michel, professor of public health in France, and the lead of the member of the 3 adverse events national incident survey that we conducted in France till now, with a big team from people from Bordeaux, Lyon, etc. This is indeed the 3rd adverse events survey in France, and I will concentrate the presentation of these results on the previous one and the actual one. So, there were 10 years between the previous one done in 2009 and this one in 2019. Just to start the presentation, I come up with a sensitive assumption, which is preventable harm to patients resulting from their healthcare is unacceptable at any time. This is indeed a sensitive assumption, as it may raise some questions for whom it is unacceptable, for the professionals, for the patients. Is it unacceptable at any time? And it relates with the definition of preventable harm and the way we measure it. Measuring is always important. And in 2004, the Ministry of Health decided to launch the first adverse event survey in France. In 2009, equally, and in 2019. The objective of these surveys was always the same: to estimate the incidence of adverse events in medical and surgical wards in acute care, private and public healthcare organizations. In 2019, the objective was also to compare with the 2009 results for 2 groups of adverse events. for the adverse events causing admissions, hospital admissions, and adverse events occurring during hospitalization. The methods were similar. So for the 2009 and 2019, these were two longitudinal prospective studies. The usual way of measuring measuring adverse events in national surveys is based on the retrospective record review method. We did slightly differently in France after having validated the method, which was published in the BMG in 2004, because we thought that the information that is in the medical records is sometimes incomplete. It was the case in 2000. It is still the case in 2022, incomplete, and we don't have many information about contributory factors related to the occurrence of adverse events. So for these reasons in particular, but for others too, we used a different epidemiological design. It was based on open population of hospitalized patients followed up for a period of 7 days maximum in a given ward. So during this 7 days of observation of what happened on the patients, the external investigators, I will tell it about it later, are surveying in the ward for these 7 days and for all the patients hospitalized during these 7 days. To guarantee the comparability of the results, the survey leader, the technical team, the design, the definitions, the tools, the investigator profile and data collection process were strictly identical. The only difference, I may say, was that we used not the same hospitals. It was not a panel survey. It was two independent randomizations of participating hospitals. The definitions are the same as all the international or the national adverse event surveys. Harm to the patient consecutive to medical management rather than to pathological process, associated with death or life-threatening conditions, liable to lead to disability or to an extension by at least one hospital stay. For the adverse events causing hospitalization, the definition of adverse events is every adverse events that cause the occurrence of at least one hospitalization day. Preventability is defined as an adverse event that would not have occurred if the care provided had complied or recommended or in the absence of guidelines commonly accepted practice at the time of the occurrence of the adverse event. So the data collection was not only based on medical record review, but also on staff interview. So during these 7 days in a ward, an investigating external nurse went 3 times in the ward and detected the presence of adverse events with the nurse supervisor and the use of the medical record using a structured interview with 17 criteria, screening criteria. After the 7-day period, an external investigating physician went in the ward and defined the presence of adverse events or not for all patients with at least one screening positive criteria, and analyzed the preventability with the doctor responsible for treating the patient. The questionnaires used for the screening and for the confirmation times were similar to those of the retrospective record review method defined for the most ancient of us, based on the Harvard Medical Practice Studies survey that were done by Leap and colleague in the late 90s. Quality control is, of course, very important. So we did unexpected visits by the survey team, made unexpected visits and verified the exhaustivity, the exactitude, the coherence of the information collected by the investigators. Each questionnaire was verified by the survey team and completed if needed by the investigators before data entering. Coherence tests in the database were performed. All adverse events was verified by one single physician from the survey team, and all cases related to healthcare products and healthcare acquired infections were reviewed by at least 3 national experts under the coordination of 2 national bodies. So, as a result, the sampling was based on the 3-stage stratified cluster survey, epidemiological design, and we randomly selected 16 departments in France among the 95. In these 16 departments, we randomly chose 56 hospitals, 2 academics, 29 public and 24 private hospitals. In these hospitals, we randomly choose 154 care units in 2 clusters, 85 in medicine and 79 in surgery. So almost equal in number of care units in medicine and in surgery. We observed a total of 4,825 patients for a total number of days of almost 22,000 days. During this observation, we find out 143 adverse events. In medicine, 80 adverse events and 43 in surgery, for an almost equal number of observation days. So you already can see that there were more adverse events in medicine in frequency. Preventability of adverse events during hospitalization, 34% of the adverse events were considered by the investigators as preventable, and for the adverse events causing admission, more than 50% were considered as preventable. So, what can we say from these results? The most rigorous indicator is the first one on this slide, is 4.4 adverse events were observed in 2019 for 1,000 days of hospitalization. It is an indicator that is quite difficult to understand, so we turn it out another way, which is 4 adverse events per ward of 30 beds per month. And this is very useful information, and this way of presenting the results is everywhere used in France when they talk about the frequency of adverse events, because it raised the awareness of every professional in hospitals. A ward of 30 beds per month for adverse events, it's quite a lot. Anyway, it's much more than the adverse events that are spontaneously identified by the clinicians in the wards. At the national level, these indicators by extrapolation means that there are some 160,000 to 375,000 adverse events in 2007 during hospital stay, medicine, and surgery. So that's the total number that we can extrapolate with some conditions for extrapolation. Roughly, we can say that between 200 and 300 or 400,000 adverse events in hospitals in 2019. Among them, because there were 34% preventable, we can say that there were between 55 and 130,000 adverse events that were considered as preventable. And just to say that in 2009, we identified between 95,000 and 180,000 preventable adverse events. So you can already perhaps understand that there were less adverse events in 2019 than in 2009. For the adverse events that were caused of admissions, you can say that 2.6% of the admissions are caused by an adverse event. It means that one admission out of 40. At national level, it means that there were 176 to 372,000 stays annually caused by an adverse event and these adverse events were generated in primary care or due to rehospitalization. What is interesting in these numbers is in this adverse event causing admission that there were two very different types of adverse events, the one that are that occur in the primary care and generated by primary care, and the one that are generated by a previous hospitalization causing readmission. So between roughly 100 and 200,000 adverse events preventable causing admissions. So that's a lot of figures. But it means that we can later discuss on more risk management things that we can learn from these figures. Economically, we can say if we take into account the number of days attributable to adverse events, a median of 5.5 days were attributable to adverse events when they occur during hospitalization, and all the days for event causing hospitalization were taken into account for the definition of attributable. So it was a median of 4 days. It means that we have between 618,000 and 1,055,000 days of hospitalization that would have been available as a total. The reporting, it was one of the objectives of the survey, secondary objective, but quite interesting. It is where these adverse events reported by the clinicians or by the clinical team at the time the investigators went in the world and identified the adverse events. And was very interested because in France, since 2016, some of these adverse events are mandatory to be reported to the regional healthcare authority it was not all the adverse events that are in the definition of this epidemiological survey, and we had only 61 adverse events that would have been reported to the regional authority and at the national level to the Autorité de Santé in the second time. So how many of these 61 adverse events were reported? Internally in the hospital reporting system, 11 of them were reported. It means 18%. And only one of these 61 was reported in the national system. So when we are looking for numbers for the estimation of underestimation of the adverse event, when we use only a reporting system, we have these results that can be used. We know that there are a lot of adverse events that are not reported. These figures give an example of this underestimation. Let's now come to the comparison between 2009 and 19. And we just focus on the preventable adverse events. These adverse events are the most important if we want to infer from these results safety plans for France. So again, it was the same data collection method. We compared the two samples in 2009 and 19. And with the exception of age and mean length of stay, all the other criteria were not statistically different. Age and length of stay, it was expected that there are a difference between the age of the people in general is increasing in our hospital. And the mean length of stay is decreasing in our hospitals. So it was not a surprise to have statistical difference for these two criteria. So comparison for the adverse events during hospitalization. There was a statistical decrease of the incidence density of the adverse events between 2009 and 19, while it had been remained stable between 2004 and 2009, the two first adverse events national surveys. In medicine, there was a trend in all specialties toward a decrease. It was not statistically there was no statistical test because the epidemiological design did not allow to compare each specialty. So we didn't do any statistics, but we observe downward trends in all specialties except for critical care. In surgery, we observe the decrease only in the academic hospitals, so not in the non-academic public hospitals, not in the private hospitals. And in the academic hospitals, we observe this decrease, except in wards with different types of surgery, means multiple specialties departments. Can discuss later the meaning of these results. According to adverse event severity, we observe also a significant decrease on the risk of vital prognosis, disability, and death. We didn't observe a decrease for the adverse events that were only causing prolongation of hospitalization. We can say that the severity of the adverse event decreased. According to mechanism, the adverse events linked to invasive procedures decrease in the interventional sectors overall, but not in for surgical procedure. It means that in radiology, gastroenterology, cardiology, everywhere where interventional sectors are, there was a decrease, but not for the surgical procedures. Regarding the healthcare products, these were also a statistical decrease for adverse events related to drugs, medications. There was also a similar classification of drugs most at risk, but there was a decrease. For the implantable medical devices, there was no decrease, the stability of the incidence. So also very interesting results. Regarding the contributory factors, you understand that our method made it possible to be quite valid in the measurement of contributory factors. I mean, it's not a perfect science because the identification of contributory factors is always related to the person that are participating. And I mean, the reliability of that measurement is not very high, but equal. It's always very interesting to see what happened. What happened was a pejorative evolution of these factors. It means an increase of contributory factors of the adverse events, an increase of the factors that were related to working conditions in healthcare establishments, human factors with a statistical significant difference. What was not statistically different, but what was observed as an increase was the poor definition of the organization and tasks, composition of the team not adequate, premise and equipment of products not adapted. You can recognize some items that are in the alarm method. Communication and supervision are very common contributory factors. These two didn't increase during these 10 years between the two surveys, did not decrease too, but there was no increase. How can we interpret this evolution of contributory factors? With two hypotheses. The first is a collection bias. We think that the investigators were more aware, more skilled to identify contributory factors, and also the clinical teams that were interviewed. Everybody is more skilled on the identification of contributory factors, so it can be a collection bias. But it can also be the reality related to the difficulties of working conditions in hospitals in France and I think everywhere. We have more and more difficult working conditions that we can identify with such a survey, which is not really done for that purpose. So I mean that if we can identify this increase in this type of survey, it means that in the reality, in the real world, with a survey that would be more valid for that measurement, it is even more important, this increase. For preventable events causing hospitalizations, the frequency decreased too, decreased regardless of the type of hospital or sector, private, public, medicine, surgery, regardless of the mechanism, invasive procedure, health product, or infection. And what is interesting, that the percentage of re-hospitalization compared to the adverse events that were generated in the primary care, the percentage of re-hospitalization increased from 26 to 42% in 2019. So we have much more adverse events causing hospitalization due to previous hospitalization than before. And this is also very interesting because we are asking what we call the ambulatory politic, which means less decrease the length of stay, but not at all conditions. And we can see that we should be cautious about the diminution of length of stay. This survey at least gives some indication about perhaps more risky situation related to the decrease of the length of stay. We also observe an increase of adverse events following surgery and not in medicine. And these adverse events following surgery were more often following rehospitalization than primary care. So we can say that this survey give an indication, an alert about the politic of decreasing length of stay at all costs, I should say. So the discussion, this is the third survey in France. We didn't see any difference between 2004 and 2009 during the two first surveys. And you understand that we found very interesting difference between the 2009 and 2019 with the very large results in terms of statistical difference. So surely, this result shows that changes in preventable adverse events can be detected by this type of survey. There is in the literature some controversy about, are these national adverse event surveys useful or not? Some people say it's not useful because you cannot identify some improvement. Just because the national programs or safety plans are directed to specific sectors, I mean infection or medication, and if you just measure all types of adverse events, you can identify some improvement. So these results show that changes can be detected by this type of survey. So we agree with some other authors that say that the health system should monitor adverse events rates over time. And because also it provides a very general sense of the burden of disease, I mean the degree to which safety problems cause measurable impact in terms of morbidity and mortality. In the other countries, all the literature reviews says two things. The first is that very few patient safety interventions have shown significant improvements in patient outcomes. So if very few interventions have shown significant improvement, this survey tends to say that if we take all the interventions as a whole, and if we follow up over time at the national level, we can, however, see some improvement. Only one country did three measurements, three adverse event surveys, is the Netherlands. And interestingly, they found the same results. I mean, between 2004, 2008, there was no difference. And the third survey was in 2012, and they observed a statistical significant reduction in preventable adverse event and in their severity during that second period. And the authors said that there is a probable link between these results and the patient safety programs. So what we can say in France about that link with patient safety programs, I just list some of the most important programs in France. The national long-term policies give us 3 programs that could have an impact. According our point of view, the hospital accreditation put quite strong in France, put a strong pressure on the hospital to improve quality and safety. We have a long-term policy on healthcare acquired infections since the beginning of the 2000s, and also an antibiotic resistance program. Since 2009, we had new policies. We could also have some impact on these results. The implementation of surgical checklists, medication safety programs, a national patient safety program dedicated to safety culture improvement. I already told you about the national reporting system of most severe adverse events that have to be reported to the regional authority, and another program on accreditation of doctors, which is the first step to the recertification of doctors. So we don't have factual data to say it is linked with the results we got, but we make the hypothesis that some of these programs may have some link with the results we observed. So recommendations. The evaluation of the National Patient Safety Program by the High Council for Public Health in 2018 indicated that France was halfway about patient safety. There was a strong framework based on regulations, tools, methods shared among hospitals, published by the health authorities under the umbrella of the ministry, but a quite poor, known and little integrated into the practice. So that's the meaning of halfway. And then this evaluation made some recommendation to define targeted objectives on operative theaters, critical care, and management of healthcare associated infections. And we see that in our results in 2019, surgical procedures, critical care are 2 areas that need more vigilance. To pursue a strong public policy devoted to safety culture, and to strengthen the governance of the patient safety policy at national level and regional level. So it was in 2018. From the results of this third assessment survey, we had some meetings at national level organized by the Ministry of Health to have a new action plan for patient safety from these results, with 7 areas that will be fulfilled with concrete actions: promoting and facilitating teamwork in the hospitals, improving skills in mitigating actions, improving reporting system and safety culture through professional patient education, safety culture measurement, information campaigns, improving the quality of root cause analysis and feedback, analyzing for improving, and not only analyzing for analyzing, and the role of simulation to improve. We also will have defined 4 specific areas: surgical theaters, critical care, implementable medical devices, and discharge organization. I mean, in relationship with the increase of re-hospitalization. And we put forward an indicator that is of interest regarding patient safety, which is re-hospitalization rate that have to be implemented. We already have a research team that, for the Ministry of Health, has defined a re-hospitalization preventable, a re-hospitalization of preventable, regarding preventable events. So that's all I wanted to share with you. I think it's in a good time. I'm quite in on a good tempo. So thank you very much for your attention. Merci de votre attention. And I can obviously answer some questions.
Yes. Okay. So thank you for this great presentation. There has been some questions in the chat, so I'll give. Okay, so I just dropped the sound for that. So there was some questions in the chat, so I will just read them to you out loud. It was in the beginning of your presentation when you showed the number of adverse events in France. So how do you explain difference of the amount or percentage of adverse events in France compared to the international standard that is 10 to 12%? Do you have any explanation for that?
Yeah. It's not an explanation. It's a, it's an answer. We got. I think in 2004, with the 2004 results, we converted, because there are differences in methodology. So it's the reason why you don't find the 10% or 12% adverse events rate. We just converted the result we got into the traditional percentage of patients with an adverse events during hospitalization, and we find it was similar to the 10%. It was 11 something. So in France we were exactly at the same level in 2004, and then in 2009 so you understand that we have a decrease of adverse events now. I have not done the exercise to convert it to say what it represents in terms of percentage of patients with adverse events during hospitalization, but we can see that it's more somehow around 8% now than 10 to 12%.
Mm-hmm. Hope that explains it. That's a sub question she asked, but are the results of these studies, you mentioned there was an article published in the BMJ in 2004, but are these results also published in English? That's the question, from 2009 and even 2019? Or is it ongoing?
2009, it was not published. We presented the results in the big conferences, the International Forum for Quality and Safety and the E-Square, but we didn't take the time to publish it. And at that time, there were many countries that were publishing their results on their national survey. So we thought it was little chance that we can publish it in a good journal, so we didn't do it. Right now, we have published these results. I presented you with the comparison with 2009 in a French paper in a French journal for now, because the first aim is to give these results to our privileged audience. But we will work during this summer to the writing of an English paper.
It will come.
It will come.
So Anthony Staines also had a question, but you might have answered that you didn't do the work to transfer everything in percentages, but maybe you can. What is the percentage of patient charts that included at least one adverse event to compare with other studies? So Anthony, if you want to pitch in, don't hesitate. But...
Yes, I think it's already been answered by Philippe, so let me rephrase my question. First of all, let me congratulate France and Philippe Michel for persevering. I think it's wonderful that you did the study 3 times. So thank you for the lessons that you shared today, and thank you for your own contribution and perseverance, Philippe. So very well done.
Thank you, Anthony.
Now, if I rephrase my question, I understand that my understanding is that you are deliberately presenting your results in a different way than the countries that have done a retrospective survey with the Harvard Medical Study protocol. You are presenting adverse events per 1,000 patient days, whereas the Harvard Medical Practice Study presents percentage of patient charts that include at least one adverse event. So could you comment on why you are choosing to present it somehow differently? Because for average people, it diminishes the possibility of comparison, but there might be other advantages that I have not perceived.
Yeah. The difference is that the traditional retrospective review is based on a retrospective design, whereas our method is a prospective data collection. And epidemiologically, you cannot use it's not possible to measure a percentage of patients with adverse events with our method, because we don't have the whole hospital stay during the 7 days follow-up observation period. You understand? We include the patients that are in the beds during these 7 days. So some patients come before the start of the data collection, and some people are discharged after the 7th day. So you don't have all stays globally, so you cannot calculate the percentage of patients because you don't have the whole hospitalization period. And I'm clear, yeah. Thank you. So it's not deliberate, it's related to the method you choose to use. And the reason why we choose to use this method is prospectively, our external investigators are going in the wards, they talk with the people, in addition to review the records, and they have more information about the adverse event itself, but more important, about the errors and contributory factors. And this is for us more important to have this kind of information than to allow a strict comparison with international results. Anyway, we know that we are not better, we are not we are comparable to other countries. Everywhere in the world, we find this, even in some developing countries, we find this level of adverse events. So the principal objective is not to ask if we are comparable. We are comparable, not better. So it's more important to get information, precise information of errors, contributory factors. It's also a way to sensitize the hospitals that are in the study, because external investigators are talking with the people there. So that's another reason why we prefer this method. Thank you.
Just to kick off, I had one question that was really, I was baffled by the numbers. How would you explain that the adverse events that were identified weren't reported in the national reporting systems, internally in the hospitals and at national level? Maybe it were preventable adverse events, and that's why they didn't like report them, or were it serious events? What kind of explanation do you have for that? And I see that one of the recommendations is to work on the reporting systems. Can you just explain how you're gonna try to do that? Because I think it's the same in every country. The
you're right. We know, I think, but Anthony will also have this this information. I think Lip, in his report for the WHO guidelines on reporting system, said that between 5 and 15% of adverse events are in the reporting systems. So it's not a surprise. Why don't the professional report? The first reason is the safety culture. They don't see the advantage. They don't understand why they should invest more time. Because when you report your event outside your world, it's always more work, because people will come back, ask more questions, ask for a report. They have to justify, to argument, okay. And we can see very clearly since 2007 2016 with that mandatory reporting to the. So we work more closely with the. I am director for quality in my hospital, and since that decree, we work much more closely with the clinicians on adverse events. It was a very good thing to make it mandatory, because clinicians now understand more. They agree to give their information to the hospital management, and before it was just internal problems, not for the director of the hospital. So very good positive consequences of that decree. And we see that even of that increase of reported events, we clearly know that every day we have adverse events occurring that are not reported, because people first think that it is not preventable. So there is no reason to take time to work on that. And my answer is, if you don't do a root cause analysis, you cannot say from the beginning that it is not preventable. We have to work on these events, even if you think that it is not preventable from the beginning. So that it is a strong argument before for not reporting adverse events. The second one is it's really an issue in our department, in our world. We want to work it before making it public, even for the management of the hospitals. We have to deal with it internally, and they want to do that. As a quality director, I say, why not? Why not? Please work on that, but give us the results of your root cause analysis. Give us the action plan, and we will follow up with you the action plan. So this is the second reason. We want to keep it for us, because this is a real issue, and we want to clinically solve the problem. So I think this is, and the third is the safety culture. I mean, for many clinicians, many healthcare professionals, they don't identify what they call complication, which is this patient is very frail. We can expect that it will make this complication, so it is a complication.
Mm-hmm.
And I mean complication not preventable. And they don't think that it is an adverse event.
Yeah, that was
so they don't report it.
Mm-hmm. That was my subsequent question. Were they all aware that the adverse events were there? That were kind of like the adverse events that you identified with the scientific team. Did the professional know that it was in fact an adverse event? And you just answered that sometimes you don't see it's an adverse event and just consider it a complication. So yeah.
Absolutely. No. And they are quite surprised. Mm-hmm. And the first reaction is to say, no, you can put it in the survey. You're just wrong. And there is a discussion between the external investigator and the doctor to say, yes, it is. We can put it in the survey. So it's also a way to raise awareness among
mm-hmm. that. Okay. So thank you for your great presentation. Thank you for answering the different questions that were asked. There was a lot of thank you also in the chat to you.
Yeah, I see. Thank you very much for all these congratulations. Thank you.
So thank you again. And for everybody, the presentation and the video will be available next week, probably.
Okay.
We'll keep you posted. And I've promised also to tell everybody in what journal you're publishing, even if it's in French, in what journal you're publishing. So we can.
Okay, I can send you the French paper. It will be published in June. So okay. I will send it to you.
Perfect. So that everybody can take a look, even if it's in French, you can read it out. Okay.
And I think this PowerPoint will be also made available by you.
Yes. Cool. Video and presentation as from next.
Thank you.
Good. Thank you, everybody. And
bye. Bye, Anthony.
Bye.
Thank you very much, Philippe.
Bye.